Assalamu alaikum, everyone. Thank you all for joining and taking time out of your busy schedules to attend. So I think we can begin now. Yeah, it's almost 6:15. Let's begin. And if other people want to join, they can later. Okay, so before I begin, so this presentation covers both part one of thoracic wall and part two. And my presentation is in no way a replacement of Dr. Atif's slides. This is just something additional to help you. Your main reference should be his slides. And, that should be your main study point. And you can use mine to help you with that and to help you understand it better. And secondly, I use mainly Moores for my presentation. So for those of you who do not have the time to read Moores, you can just go ahead and look at my presentation. It has most of the pictures from Moores and a lot of the text from Moores as well. So that's that. And there are a few slides that I'm going to be covering from Dr. Atif's PDF towards the end of the presentation. I've left quite a few minutes for you guys to ask me any questions, re-explain stuff, and all of that. And yeah, that's it. So please participate in the questions and pay attention. And if you have any question, stop me right away. This is supposed to be an interactive session. I don't want to be a professor here and teach you guys and not have you guys interact with me. Okay, you're free to unmute and type a question in the chat box. Okay, so let's begin. So my name is Hibara Hill. I'm a fourth year medical student, and I'll be talking about the thoracic wall today. My email is written there in case you have any questions. So these are the objectives. Let's just dive right into it. So we're speaking about the thoracic wall. What is a thoracic wall? So what is a thoracic cage? It is basically a bony structure. It's made up of muscles, and it's made up of different nerves and blood vessels and bones. And it's this protection that forms around vital organs in the thorax and the abdomen, right? So what are the vital organs that we have in the thorax and the abdomen? We have the lungs, we have the stomach, we have almost the liver also in the thoracic region. So the thoracic cage, which is this bony structure, it encases all these vital organs and it protects it from any damage. They also resist negative internal pressure because when you breathe in air and the lungs recoil, they relax first and then they recoil, right? When they do that, there's a negative energy or negative pressure that's generated inside the lungs. So the role of the thoracic cage is to oppose that. Otherwise, everything inside the thoracic cage would basically collapse. So it doesn't want that to happen, right? And then they provide attachment and support for the upper limbs, because where are the arms connected? They're connected to the thorax, right? And they also provide as an attachment for all the muscles. So every muscle in the body has to be attached somewhere for it to work and contract, right? So the thoracic region also provides attachment for important muscles. So you guys have done MSK. Tell me a few muscles in the thorax that attach to the chest wall or the rib cage. You can say it in the chat or you can unmute. Honestly, I don't mind. Very good. Serratus anterior is one. What else? Very good. Pectoralis major. What else? Good. Pectoralis major and minor. So these are just a few muscles that do attach to the chest wall or the thorax. Okay, so let's talk about the bones. So the way I've divided the lecture is I'm going to talk about the bones, then I'm going to go into the muscles, and I'm going to talk about the nerves and the arteries and the veins, and then we're going to talk about some organs and their blood supply and nerve supply, okay? And then anything that's left, we're just going to cover it from Dr. Atif's PDF. So first, let's discuss the skeleton itself, the bony structure itself. So it's the way our rib cage is formed is very unique in the sense that it's both bones as well as cartilage. So it's called the osteocartilaginous thoracic cage, right? Osseous means bone, and cartilaginous comes from the word cartilage. So there are in total 12 ribs in the body. we have the true ribs from the first to seventh rib are the true ribs. These are the ribs that directly attach to the sternum. The sternum is this bony flat bone in the center of your chest, and it directly lies above the heart. So you can actually feel it if you put your hand here. So the true ribs are those ribs that attach directly onto the sternum. These are called the vertebra-sternal ribs, okay? So it's the first seven. And how do they attach? They attach through a cartilage. So this cartilage, this white grayish structure that you see, this grayish thing, this is the cartilage. Then we have the false ribs. So the false ribs are those ribs that have a cartilage, but their cartilage indirectly attaches to the sternum. So 8th, 9th, and 10th, their cartilages fuse and then they attach to the sternum, okay? So here we have 8th, 9th, and this is the, 8th, 10th, 9th, and 8th. Their cartilage, as you can see, they form like this V thing, they fuse, and then they indirectly attach to the sternum. So this is called false ribs or vertebra-chondral ribs. The word chondra comes from cartilage, right? So they all attach to the cartilage and then to the sternum. And lastly, we have the floating ribs. Now, the floating ribs have no attachment anteriorly. In the front, there is nothing attaching them. They come from the vertebra at the back, and then they just hang loose. And they're not attached to any cartilage, and they're not attached to anything above. Okay, so do they fuse with the cartilage of the seventh rib? Yes, exactly. So they fuse with the cartilage of the seventh rib. Oops. So 8th, 9th, and 10th, their cartilages come together. They join the seventh ribs. As you can see here, this is the seventh rib. They join the seventh rib and it goes up and they connect to the sternum. Okay, now let's talk about the sternum. So the sternum is this flat, elongated bone, and it's present right in the middle of the thoracic cage. And it protects against the visceral organs, especially the heart. So there are three main parts to the sternum. We have the manubrium, the body, and the xiphoid process, okay? Again, the manubrium, which is the top part, this is the body, this one, and the xiphoid process is kind of like the last portion, the tip. So the manubrium, which is the topmost part, is the widest and it's the thickest. And it's the widest and the thickest of all the three parts. And you can actually feel it here. If you put your hand here, you can feel it. And one special thing about manubrium is that it forms the jugular notch, which is very important when you're doing your physical examination. And as part of your pro sessions, it's very important for you to identify where the jugular notch is. So if you put your hand right under the base of your throat, you can feel this indentation. That's the jugular notch. And it's the manubrium that forms it, the superior part of the manubrium. Then this angle is also very important, the angle of Louis. So the angle of Louis is basically the point between the manubrium and the body. And the manubrium kind of just goes like a little anterior to the body. So it creates this like slight protrusion, okay? Which is what you can feel at the second intercostal space. So when you start feeling for the ribs, you first locate the angle of Louis. And how do you do that? Because it's very prominent. And this prominence that you feel, that's actually the manubrium poking out. So you feel for that, and then you can move one finger space down. And that's how you feel for the ribs and the intercostal spaces. And lastly, we have the xiphoid process. This is at the 10th vertebral level. And this is very important to know because this comes a lot in OSCEs, they ask you this. And xiphoid process is kind of like the reference point to everything. We say, okay, so the xiphoid, the tip of the liver is present at the tip of the liver starts, the upper border of the liver is present at the tip of the xiphoid process. So xiphoid process is very important to identify. So this is one thing that you really need to remember, that the tip is at the 10th vertebral space, in the 10th vertebra, sorry. All right, now, do we have any questions regarding the bones, whatever I've discussed so far? Type yes or no in the chat and let me know if I should repeat anything.
May you repeat the things that are in the 10, T10.
Okay, so you want me to go here?
Yes.
Wait, T10? Sorry, so you
No,
want me to
not this slide.
Xiphoid
Yes,
cartilage.
yes, yeah.
Okay. All right, so if you see this tip, this thing, do you see this here at the very bottom? This is called the xiphoid process. It's just an extension. Think of it like a tail of the sternum itself. So the sternum ends at the 10th vertebra. So if you draw a straight line from this tip and you take it all the way to the back, it's going to align with T10, the 10th thoracic vertebra. And the reason why it's important is because then you can start counting from there onwards. So it's kind of like the ending of the thorax and the beginning of the abdomen. But just remember that the xiphoid process, this tip ends at T10 vertebra. Okay. Okay. Any other questions? Oh, can we say, I have a question that someone's asked that, can we say that 8, 9, 10 fuse with the 7th costal cartilage and attach the xiphoid process? No, they actually attach to the body of the sternum. So it's like between the body of the sternum and xiphoid. So you can't really say it's the xiphoid process. Just don't specify. Honestly, the more you specify in the exam, the more you're basically digging your own grave. Just say it attaches to the body of the sternum. That's the safest answer you can go with. Or just say it attaches to the sternum. That's it. All right, so the muscles. Now, aside from the big muscles that you guys mentioned that are already present in the thorax, we have some other muscles. So I'm not going to go into pectoralis major, minor, and serratus anterior. These are things that you already would know because you've discussed this in MSK, but I'm just going to talk about the muscles that are present in between the bones. Now, please, 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 this is so important because usually this comes as an OSCE in the exam. It comes as an OSCE station, or it can also come as an SAQ. So something like, for example, the surgeon was doing an incision, which one of the, in the rib cage, so which one of the following layers would they pierce and stuff. So this can come as another type of question, okay? So keep this in mind. Now, the intercostal muscles, they occupy the intercostal spaces. Now, what are the intercostal spaces? There are the spaces between the two ribs. So each rib has a space between it, and this is called which means between, intercostal space, okay? So we have 3 different types of muscles that we're going to discuss, okay? The external intercostal, and the external intercostal are 11 pairs, which means 11 on one side and 11 on the other side, okay? They're 11. Why aren't they 12? Because there are 12 ribs. So why aren't there 12 pairs of external intercostal muscles? Who can tell me? It's okay, you can unmute, you guys. I want you to interact with me. Tell me why there are only 11 pairs. Exactly, because there are only 11 intercostal spaces. Below the 12th rib, you have nothing. That's where the liver starts, or the stomach starts, or like the abdomen basically starts, okay? So below the 12th rib, there is nothing. So there are 11 spaces between the ribs. Although there are 12 ribs, yes, but there are 11 spaces in between, okay? And so the external intercostal muscle is the most superficial layer of muscles. And they're most active during inspiration. This is very important to know, okay? Most active during inspiration. Now, one thing that I would like to mention here is that inspiration is when we use the muscles, okay? So we're using the diaphragm, we're using our interosseous muscles. So it's basically an active process. Why? Because ATP is being used, energy is being used in inspiration. Expiration is basically the recoil of all these muscles, the recoil of the diaphragm. So that is a passive process. It's not an active process. So you would see later on that, okay, this muscle is used in expiration, but know that it's very slightly used, okay? So inspiration, external intercostal muscle is very important. The internal intercostal muscle is also 11 pairs, and they form the inner layer, okay? So not the innermost, the inner layer. So we have external intercostal, then the internal intercostal, okay? And they're most active during expiration. Why? Because of the way the the fibers of these muscles are oriented. That's what determines whether it's important during inspiration or expiration. The last layer that we have, the deepest layer of muscles that we have in the thoracic cage is the innermost intercostal muscle. This layer is basically formed from the deepest fibers of the internal intercostal muscles. When I was doing CVP in my year one, they didn't even teach us innermost because they were like, it's not true because it's basically the inner intercostal muscles forming the innermost layer. But yeah, it's also used in inspiration mostly, okay? All right, now let's go to the innervation.
I
Now,
have a question.
yeah, go ahead.
It's different, the internal intercost muscles.
Yeah.
It's different with the intercostal muscle.
Okay, so the intercostal muscles are of three types: external, internal, and innermost. So intercostal is just the term. Intercostal means between the costas, between the ribs. So it's the same name, but it's in different places. This muscle is located in different places. So we have an external, an internal, and an innermost. Does that make sense?
Yes, thank you.
Yeah, okay. So here, it's the external intercostal, then we have the internal intercostal, and then the innermost intercostal. And then on top of that, you have stuff like pectoralis major, you have pectoralis minor, you would have the serratus anterior, all attaching to the sides, okay? All right, now this is very important. Why is this picture here very important? Is so that in the exam, they can give you something like, for example, a 70-year-old man fell down the stairs, and when he came to the ER, he could not feel his shoulder, like the sensory nerve supply on his shoulder. So which one of the following vertebral level is most likely damaged? Or nerves at which of the following vertebral levels are most likely damaged? So you would have questions like this in the exam. For that reason, it is important for you to know these dermatomes, okay? So it's actually, okay, so someone's asked me, is it inactive or what? Like, I don't understand. What do you mean inactive? Let me know what you mean if the innermost intercostal muscle is inactive or not. Okay, so the dermatome is basically the sensory nerve supply of the nerves, right? The skin is called the dermatome. So what part of the skin is innervated by which nerve? So it's actually not that difficult. It aligns with the ribs. So T2 aligns with the rib number 2. T3 aligns with the third rib. T4 aligns with the fourth rib. So the abdomen is actually very easy. What I would recommend you guys focus on is this arm region, because that can get a little tricky, okay? So there are 12 pairs of thoracic nerves that supply the thoracic wall. Now, the ribs attach to the thoracic vertebra. That's why there are 12 pairs of ribs and 12 thoracic vertebra, okay? So don't confuse that. So every time there's a rib, it attaches to the thoracic vertebra. It does not go to the cervical. It does not go to the lumbar region. And along with that, along with the ribs, you have, 12 pairs of thoracic nerves. Do you remember? You must have done this in foundation where they taught you spinal nerves, and then there are this many thoracic nerves and this many cervical nerves and stuff. So there are 12 pairs of thoracic nerves, and these nerves run along the ribs on either side. So these nerves are spinal nerves, which means they're mixed in nature. They have both the motor supply as well as the sensory supply. So for those students who joined us in pre-med, I was one who taught this lecture about the spinal nerves. And I told you guys, if you remember, that spinal nerves are mixed nerves. They have both motor nerves as well as sensory nerves. So they supply both muscles, myotones, and dermatomes, the skin. And then the spinal nerves, they come out of the foramina, and then they divide into anterior and posterior rami or branches, okay? So the anterior branches of T1 to T11, meaning the nerves that come from T1 all the way to T11, their anterior branches, they form the intercostal nerves, okay, that run in the intercostal spaces. And then these anterior rami and the anterior rami of T12. So I said T1 to T11, their anterior rami form the intercostal nerves, right? Now, what about T12, the last thoracic nerve? That one forms the subcostal nerve. Sub means below. So this nerve goes underneath the 12th rib, which is the floating rib. All right. Do we have any questions? Any questions for me? Because I know this slide is a little confusing before we go on to the arterial supply. All clear. Okay, great. All right, so during the checkpoint, I will answer your question about the expiration and inspiration, okay? But any questions on this innervation? Do you want me to repeat anything here? I can, I don't mind, we have time. Okay, since nobody wants, okay. What is the type of question in the exam? Okay, so in the exam, you're going to get something like a trauma case, some man or woman got hurt, and they're going to come with like pain or something, and the exam question will say that as a doctor, you examine them and you realize that they don't have sensation in, let's say, the superior aspect of their arm. Which one of the following nerves is damaged? Or they don't have sensation in the, let's say, the inner part of the arm. Which segment of the spinal nerve is damaged? These are the kind of questions that will come in the exam. You must know what part of thoracic nerve supplies what dermatome in case that there's an injury to that level, so you can correlate it to the area that won't have the sensory supply. Can I repeat about the dermatome and the myotome? Okay, so spinal nerves are mixed nerves. That means that they contain both nerves or branches that supply the muscles and the branches that supply the skin, okay? So the branches that the motor nerves that supply the muscles, they supply the myotomes, which means the muscles. The sensory nerves, which supply the skin, supply the dermatomes. So spinal nerves are both myotomes and they supply dermatomes, okay? So the intercostal nerves have both. The intercostal nerves, the nerves that run between the rib cages, they have both. Myotomes, they supply myotomes and dermatomes, which means they have both motor nerves and sensory nerves, okay? So I hope that's clear. All right, now let's go to the blood supply of the rib cage. So everything in the rib cage, it goes in along the spaces between the ribs, okay? Everything, whether it's nerves, whether it's arteries, whether it's veins, whether it's lymphatics, everything goes literally like this in like half circles. So the arteries are similar to the nerves. The arteries, the thoracic, now this is discussed in more detail in Dr. Atif's lectures, but I'm going to mention what are the three main arteries that you must need to know for the exam, because this question does come, but for like the small details, refer to his presentation, his PDF. Okay, so the first artery that you need to know is the thoracic aorta. So the aorta leaves the heart, then it first becomes the ascending aorta, then the arch of aorta. Over here, you can see the arch forming, and then it becomes the descending aorta. It goes into the thorax, it becomes the thoracic aorta, goes into the abdomen, becomes the abdominal aorta. So in the thoracic region, the aorta gives 12 branches, 12 pairs. It gives branches to supply the areas between the ribs, to supply the muscles, right? So the thoracic aorta gives posterior intercostal and subcostal arteries. So subcostal arteries are two, okay? There are two subcostal arteries, one on each side. Subcostal artery is the last artery under the 12th rib, the floating rib. Just, it's similar to the subcostal nerve. the last rib, the last rib, the 12th rib that is floating, underneath it, we have an artery, a nerve, and a vein. Three things. So thoracic aorta, from the back, it gives rise to posterior intercostal arteries and subcostal arteries. Then we have the subclavian artery. The subclavian artery is, let me show you if we can see it here. Okay, so the subclavian is here. Yeah, so this is a subclavian. So the subclavian gives rise to the internal thoracic and the supreme intercostal arteries. So supreme intercostal arteries are at the very top, okay? Next, we have the axillary artery. So the axillary artery gives rise to superior and lateral thoracic arteries. Now, these are the three, for the exam purpose, please go into details with Dr. Atif's lectures. I'm just giving you a brief overview of the different types of arteries, but I'm just giving you the most important things that you need to know. You must know the names of these three arteries, okay? And the intercostal arteries, they go through between the ribs. And like I said, that they supply the muscles and the bones. All right. And each intercostal space is supplied by three arteries. Remember how we said that that we have a posterior intercostal, we have an internal intercostal, then we have a lateral intercostal. So each intercostal space, each space between the two ribs, have three arteries. We have one big posterior intercostal arteries and two small pair of anterior intercostal arteries. Think of it this way. The thoracic aorta is a very, 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 very big and very wide blood vessel, right? So it gives rise to the posterior intercostal artery, which is large. So there's only space for one large posterior intercostal artery, okay? And then the anterior intercostal artery are smaller, and they're only two, and they come from the subclavian artery. Okay, so I have questions. Okay, can I repeat this part? What part do you guys want me to repeat? Yes, motor branches are for myotomes and sensory branches go to dermatomes. Yes. What part do you want me to repeat? Do you want me to repeat the arteries itself?
Yes, because I didn't understand about the descending artery.
About what artery?
Descending aorta.
Descending aorta. Okay. I'll go ahead. I'll explain it again. Don't worry. Okay. So what I was saying here is that from the heart, when the blood vessels come out of the heart, when the aorta leaves the heart, it first forms the ascending aorta, which means it leaves the heart, so it goes up, ascending, and then it forms an arch, which you can actually see here. This forms an arch. This is called the arch of aorta, from which you have various blood vessels coming. No need to go into the details of that. Then the aorta turns and goes down. It goes down in the thorax. This segment is called descending aorta, or it can be called thoracic aorta. So it becomes descending and then it becomes thoracic aorta, okay? So it's the same blood vessel. It's just that wherever it goes, we just give it different names. I don't know why they like to complicate it, but it's the same blood vessel. It just, where in the different regions of the body, it has different names. And then it becomes abdominal aorta. Now, there are three arteries that run between ribs. Each rib, between two ribs, there's a space, right? There are three arteries that run through that. You have one posterior intercostal artery and two anterior intercostal arteries, okay? Now, where do these blood vessels come from? What is the origination? They come from three important arteries that you must know about. Thoracic aorta, which is this big part of aorta that you see over here. This part, it's called the thoracic aorta. Let me see if I can use the pen to annotate. Yeah, here. Right. Okay, so this part is the thoracic aorta. Can you guys see my pen? This part is the thoracic aorta. It gives rise to posterior intercostal and subcostal arteries. So this part, posterior intercostal arteries, come from thoracic aorta, and this part, subcostal artery, which is the last artery that is at the very, very, very bottom, runs below the 12th rib. Can you see it's coming from the thoracic aorta right over here? Then we have the subclavian artery, which gives rise to internal thoracic and supreme intercostal arteries. So internal thoracic is right over here. This comes from the subclavian artery, which is here. Okay. Last artery that you need to know about is the axillary artery. Okay. Now, how can you remember this? Think of it this way. The thoracic aorta is a very big blood vessel. It's a very wide, very strong blood vessel, like you can see over here. So it gives rise, sorry, I can't see my cursor. So yeah, it gives rise to the large posterior intercostal artery. Is that clear? Clear, you guys? Okay, all right. Let's move on. Okay, so now let's talk about the veins. Now, again, this is going to be, you will see this in more detail in Dr. Atif's lecture. But I will tell you like the main important thing that you need to know for the exam purposes and the questions that I saw, for example, in like the question banks. So there are intercostal veins that follow arteries. So here's a general rule in the body. Wherever veins go, arteries follow, okay? So they're almost always given the same name. We have, again, 11 pairs of posterior intercostal vein and one subcostal vein on each side, just like the arteries. In between, we have 11 pairs. In between the ribs, we have 11 pair and just one vein at the bottom. All right. Next, we have that. So next, the posterior intercostal veins, they anastomose with the anterior intercostal vein, and they form this one vein that drains into the bigger vein. So whenever we use the terms, for example, branches, we mean arteries. When we use the word tributaries, we mean veins, okay? So veins, they go from small, 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 they join, and then they form a big vein, and they enter ultimately into the bigger vein. The arteries, they go from big, big blood vessels, and they branch, and they go into smaller branches and arteries. Clear? So the posterior and anterior intercostal veins, they join together to form a common intercostal vein, which then drains into two different things. Now, this is very important for the exam, okay? The 4th and the 11th intercostal vein drains into the azygous and hemiazygous venous system. Okay, I'm not going to get into what azygous and hemiazygous is, but you must know, and this is so important, that 4th to 11th posterior intercostal veins, they drain into the superior vena cava. Okay, superior vena cava. And the superior intercostal veins, which are at the top, they directly drain into the left brachiocephalic vein. These 2 points are so important. Again, for the sake of the exam, I'm going to repeat it one more time. The posterior intercostal veins, 4 to 11, they drain directly here, right at this part, right where my cursor is, at the superior vena cava through hemiazygous and azygous venous system. Just memorize the name and just, but this is the fact, like it makes sense. The superior vena cava does not form till T4 and T4. It does not form till T4. So that's why there's no space for all these veins to drain anywhere else. It by default, they drain into the superior vena cava. But the superior intercostal veins, because there is no superior vena cava at this level, they drain into the left brachiocephalic vein. Okay, so before we get to the checkpoint, let me read the questions. So can we say that posterior ICA are from thoracic aorta and anterior ICA are from internal thoracic artery? Yes, you can. Yeah, absolutely. Do you have any questions? Do you want me to repeat anything? You can unmute if you want any questions. I think there was a question at the top. Yes. Someone asked earlier that during inspiration or expiration, oh, okay, so innermost muscle layer is involved in inspiration, not expiration. And is it active or passive? So I said that inspiration is active, okay? Passive is expiration. So the muscles in our body are out, so it's passive, does not require much ADP. Okay, let's move on to the checkpoint. All right, so who wants to unmute, read, and answer the question? Any volunteers?
B.
Okay, what about the rest? Do you guys agree with her? Yeah, any other people? Any other opinions, comments, anything? Yeah, it's B. The answer is B. I think this was a very simple one. It was just to like make you guys aware. Okay. Yeah, so it's B. All right, so this is kind of tough, but I focused on it so much, so I think that you guys should get it. Most of the drainage of the thoracic body wall reaches the superior vena cava, with the exception of left superior intercostal vein, which drains into the
A.
excellent left brachiocephalic vein. Very good. Good job, everyone. Okay. All right, so now let's move to the second part. So here's what we'll do. We'll finish the pleura. We'll take like a 5-minute break or a 10-minute break, and then we can come back and then we can finish the rest, okay? All right, so let's begin with the pleura. So basically, what is pleura? Pleura is just the space, okay? Just like thorax is a space, the thoracic region is a space. Pleura is inside the thoracic region, okay? It's a space which contains the lungs, all right? And within the pleura, you have the mediastinum, which contains the heart. So the pleura is covered by any covering, just like any covering in the body, any surface in the body is covered by something, right? Like our body's covered by the skin. So think of the layers of the pleura as skins. You have the visceral pleura and the parietal pleura. The visceral pleura, it covers the surfaces of the lungs and it forms the shiny surface. So if you go to the lab, the anatomy lab, the wet lab, and you see a lung, not like from the old cadaver, no. If you see from like a fresh cadaver, you will see that it has a shiny covering on top. Okay, this shiny covering is the visceral pleura. I wanted to include a picture of the cadaver here, but I couldn't find good ones on Google. So guys, just see it when you go to the lab, all right? So visceral pleura is the shiny covering which goes right on top of the lungs, and you cannot separate it. No matter what you do, you cannot separate this layer. The parietal pleura, what does the word viscera mean? Viscera means organs, right? So the covering that covers the organs is visceral pleura. The covering that does not cover the organs, that covers the surfaces, is called the parietal pleura. So parietal pleura covers the cavities, the empty space which the lungs sit in, okay? And they stick very firmly to the thoracic wall and the mediastinum. This is one of those layers that you can peel. So I don't know if any TA showed you this in the lab, but you can peel the parietal pleura. Like you can see it. It's like this fibrous material that you see. Okay, go see it in the lab. And in between these two pleuras, the parietal and the visceral, you have the pleural cavity. The pleural cavity is filled with fluid. Think of this fluid as a cushion, okay? Just like during pregnancy around the fetus, in the amniotic sac, in the uterus, we have a fluid that develops around the fetus, right? It protects the baby. It protects it from shock and it lubricates and everything. This is the same thing that occurs in the pleural cavity. So in this pleural space, you have this fluid, which is there for protection. And it's there to make the lungs stick onto the pleural cavity. So the lungs, they don't move while you're running and while you're moving. All right. Now, let's go to the lungs. Do you guys want to take a break now? Or do you guys want me to continue and then we can finish early? What do you guys want?
Yes, please. We want a break, please.
You want a break? Okay, go ahead. Take a break. Guys, give me your opinion in the chat because, like, honestly, we'll go with whatever majority say. As I like. No, I honestly, I'm leaving it up to you guys. You guys are the ones who are listening. Oh, I continue. So that's what majority say. Okay, how about this? Let's take a 5-minute break, come back at 7. Okay, so for those who don't want to take a long break, come back at 7. In the meantime, if you want to stay back and ask me some questions, you're more than welcome to. Okay, so someone asked me a question in the chat. Okay, let me go back. About something in the veins. Okay, here. So the question is, both the right and left superior intercostal veins drain into the right and left subclavian vein. Okay, so here's the thing. Yes, both the right and left 4 to 11 intercostal veins drain into the superior vena cava. Okay, both right and left. Clear? Okay. Only the left superior intercostal vein drains into the left brachiocephalic vein. Clear? It's left brachiocephalic vein. There's no right brachiocephalic vein. There's only left brachiocephalic vein. So it can only be left superior intercostal vein, 1, 2, 3, 4, that drain into the left brachiocephalic vein. Clear? 4 to 11 posterior intercostal veins drain into the superior vena cava. I hope that's clear. Do you have where the superior okay, so the superior one, it drains into the just a second. Yeah. Okay, the superior one, it drains into the left brachiocephalic vein. Okay? The right one, yes, the right side. And the left one on the left side. I think I said earlier that there is no right, but there is no right brachiocephalic artery. Sorry, there is a right brachiocephalic vein, as you can see on this side. Thank you for asking this question, and I'm sorry for the slight confusion here. So there is a right brachiocephalic vein, and then there is a left brachiocephalic vein, okay? So the left side drains into the left, the right side drains into the right. Whereas 4 to 11, they drain into the inferior vena cava. What are the tributaries of the anterior vein? I'm not sure about the tributaries of the anterior vein. I'm not sure. That's a good question. Send me your email and I'll get back to you on that. I'm not sure. I'll get back to you on this. And let me write your question down. And you can send me your email, or I can just send it to Idris, and I will tell him the answer to this question. Any suggestions on how to study CVP physiology? Okay, CVP physiology was actually one of my favorite kinds of physiology because it just made so much sense. I studied it from Gaiden mostly because I know it's very, very, very extensive and it takes so long. But honestly, if you just If you just read, like, you don't need to read the whole chapter. Even if you read like the beginning parts, it just builds your basis so much that you start to understand the presentations even better. And I know Dr. Abdul Jabbar loves Guidon. He loves Guidon. That's the only reference that he uses. So I would highly recommend Guidon. It takes a while, yes. But again, highly recommended, highly recommended. If you don't have time, you can ask one of your friends, like you can assign your friends different pages from Guidon, and you can come together and explain it to each other. But honestly, I would just recommend for CVP, you study Guidon. What's Sham's slide? I don't know. Is that a studying resource? I have no idea what this is. We didn't use it.
I'm not sure, but maybe he's a doctor, but maybe he didn't teach you.
Oh no, I don't think he taught us. I think at that time we had different professors, to be honest. We had two professors that left. Oh, he just started last year. Yeah, we didn't have him. Honestly, I don't know, but here's like my advice, whether it's Dr. Abdul Jabbar or anyone else, I highly recommend you do Guidon. If you cannot do Guidon, do Guidon review. Okay, you would be confused if you didn't read Guidon book. Guidon review is very good for that. Oh, he's the new director for CVP. Yeah, we didn't have him. We had something different.
Shall we start now, please?
Yeah, let's begin. Okay, it's 7. Yeah, let's begin. Okay. All right. So let's start. We're done with the pleura. Now let's go to the lungs. Okay. Now, the lungs is the main focus of my presentation, and I did my best to like simplify it and stuff. If there is anything that you guys don't understand, please tell me, just like before. And yeah, so the lungs are, as we know, baby stuff, are responsible for respiration. Now, what are the parts of the lungs? So first thing that you need to know is about the apex. So this right here, the very top part is called the apex. Okay, this apex is like a blunt superior end. It's a superior end, and it's like present right behind the clavicle. If you put your hand behind the clavicle, deep inside this indentation, that's where the apex of the lung is. It's so high up. And it's present above the level of the first rib. So if the first ribs start around here, the apex goes above. It's that high. And it's covered by cervical pleura. So it almost goes into the root of the neck. So like here. The base of the lung is the inferior surface. Okay. So this bottom surface, which meets with the diaphragm, is the base of the lungs. Okay. Now, the lungs have lobes. I'm sure if you've been to the lab, if you've seen a lung, you can see that it has sections. These sections are called lobes. And depending on the lung, what kind of lung it is, there are different number of lobes. Now, we'll get into that later. Now, this is like the most important part of the presentation starting now, okay? The lobes are formed by fissures. So think of fissures as lines that run on the surface of the lungs. And they're deep lines that run on the surface of the lungs, and they separate the lungs into sections. They separate the lungs into lobes. Depending on the lung, there are different numbers of fissures and different numbers of lobes, okay? We'll get into this in a bit. There are 3 surfaces of the lungs, okay? So the lung, think of it, imagine the lung in your head, okay? There is a surface that meets the heart in the middle. Then there is a surface that meets the front. And then there is a surface that meets the bottom, right? So we have a costal surface that meets the rib cage. We have a mediastinal surface that comes in place with the heart. The heart is present between the lungs. So the mediastinal surface faces the mediastinum. And then we have the diaphragmatic surface, which is at the bottom, which is where the diaphragm is, okay? And it has 3 borders. We have the anterior border, we have the inferior border, and we have the posterior border, Okay. Now, this is an extremely important slide. So like I'm ready to spend 10 minutes on this if you guys want me to, okay? This almost every single time, every year comes as a question, as an OSCE station. They can give you two pictures, ask you to identify what lung is which. In the lab, you know, they would give you two lungs and tell you which one is right, which one's left. So yeah, very important slide. Okay. So how to differentiate between the right lung and the left lung? So first, when you look at the lungs, first thing you notice is which one is longer, which one is shorter, which one is wider, which one is thinner, okay? The larger one, the one that looks big, and the one that looks like heavy, and it looks short and wide, okay? So it looks heavy. When you lift it, it's going to be heavy, and it's going to be short and wide. So it's like this and a little short. That is going to be the right lung. Your left lung is actually thinner and it's a little longer, okay? I have very important notes, by the way, in my notes section. So if you guys see here, I have very important notes, and like almost whatever I'm saying is going to be present in the notes, okay? So make sure that you read my notes. Why is the right lung shorter than the left lung? It's because the right dome of the diaphragm is higher up. Because on the right side of the body, we have the liver. The liver pushes a little and it pushes against the diaphragm. When it pushes against the diaphragm, it pushes the right lung, and that's the reason why it's shorter, okay? And on the left side, we have the heart. The heart kind of, remember how like they say that the heart is like kind of tilted towards the left side? Because of that, it pushes against the left lung. That's why the left lung is thinner and it's taller, longer. Okay. All right. The right lung has two lines, two fissures or two lines. We have the right oblique and we have the horizontal fissure. Now, this is very important. Why do we say right oblique but not right horizontal fissure? Because we do not have the horizontal fissure on the left lung. That is only present on the right lung. We have an oblique fissure on the left lung. That's the reason why it's called right oblique fissure, left oblique fissure, okay? And because there are two lines on the left lung, on the right lung is divided into three lobes: superior, middle, inferior, okay, over here. So this is the right lung. We have the horizontal fissure, and then this one right over here, it's the right oblique fissure. As you can see here on the left line, there is no horizontal fissure. We have only one fissure, and it's called the left oblique fissure. So the right lung is divided into three sections: superior lobe, inferior lobe, and middle lobe. Clear? The left one is only divided into two: superior lobe and the inferior lobe. All right. The left lung has a larger mediastinal surface because I just mentioned that most of the heart is towards the left lung, so it has a larger mediastinal surface. For the right lung, the border is straight, the anterior border is straight, whereas for the left lung, there's a deep cardiac notch. Again, I just mentioned that the heart is present towards the left side a little, so it's kind of pushing into the left lung. That's why the left lung has like an imprint. It has like an imprint of the heart. Like it's like how you walk on wet sand and it leaves a footprint on wet sand. Similarly, it's the same thing in the left lung. Because of the heart being against the lungs of the left lung, there's like an imprint of the heart on the lung. So the anterior border of the left lung has a cardiac notch. And the right lung has two bronchi, whereas the left lung has one bronchi, okay? The left lung has a linguala. What is a linguala? I said that it has a cardiac notch, a deep cardiac notch, right? Because of the position of the heart, think of it this way. There's like a small part of the lung that kind of dips down. I'll show you what a linguala looks like. That is present on the left lung, okay? So L for linguala, L for left, L for lung. Okay, so lingula is present on the left lung, not on the right. All right. Is this clear? Is there anything you guys want me to repeat here? Do you guys want me to go over the table again? Is there anything that I should go over here? Okay, I repeat lingula. Okay, let me see if I can find a picture of lingula. I think it would be better explained here. Okay, so, okay, it's not here, but when we see a picture of lingula, I'll tell you what it is. So lingula is formed because of the heart being against the left lung. Because it's pushing against the left lung, it causes a little bit portion of the inferior of the sorry, just a second, let me go back to the picture. Yeah, it causes a little bit of the inferior lobe to kind of bulge down, kind of dip down. When it dips down, it forms this thing called lingula. It's part of the lung. It's lung tissue, but it's just because of the heart being there, it has this like small dip. Okay, that's how you can, this is one of the major things that you can identify. Can I explain the fissures again? Of course. So they are different number of fissures present in both right and left. Right lung has 3 fissures. Okay, 3 lines that, sorry, has two lines that run deep into the lung. These lines divide the lungs into portions, into segments. We have the superior segment here, the inferior lobe, and then the middle lobe. So right here, this line that you see right here running right through the middle, this is called the oblique line or the oblique fissure. This right over here, it's called the horizontal fissure. So the right lung has 2, the left lung has 1. Because of the fissures being 2, the right lung is divided into 3 parts and the left lung is divided into 2. There is no middle lobe in the left lung. All right. So when we're identifying an OSPE, what's the main thing we should focus on? Okay, so main thing you should focus on, the first thing, like if they give you 2 pictures, first try to identify which lung looks bigger to you, which lung looks smaller to you. The shorter lung would definitely be the right lung. The bigger one would definitely be the left lung. Then try to look for the lobes. If you see 2 lobes, left lung. You see 3 lobes, right lung. This table basically would help you in OSCE, okay? Then try to look for lines. Maybe you can't see the lobes, maybe you can see the lines. Try to look for the fissures. 3 fissures, right lung, 2 fissures, left lung. Then try to look for the heart, the cardiac imprint, okay? So if you can see, there's this really nice picture up ahead, but I don't want to go because I have a question for you guys. But if you can see over here, this deep imprint, deep like imprint that you see over here is the cardiac notch. This is the heart against the left lung. I'll show you in a really nice picture in front. That definitely is your clue that this is the cardiac notch. It's bigger. You have the aorta over here as well. You'll see the arch of aorta. You can see the aorta going down. This is like the imprint left by the aorta. This definitely is the left lung. The right lung would not have that. All right. You can see that. I'll show you that in the picture ahead. Okay. All right. So let's go to our question. What feature is only found in the left lung?
D.
Think again. Okay, I'll give you guys a few minutes to think.
I'm not sure, but maybe C.
Okay, all right, so let's go back to this picture. So which feature is only found in the left lung? Only found in the left lung. So horizontal fissure, no. So horizontal fissure is only found in the right lung. And yes, whoever said cardiac notch, it's correct. The cardiac notch, it's right over here, sorry, this part, and it's only found in the left lung. The 3 lobes, no, it's the right lung that has 3 lobes. Left lung has 2 lobes. Okay. Okay, how can you memorize this? Think of it this way. The word right is bigger than the word left. So right has 3 lobes, left has 2. Okay. Come up with like stupid stuff like this to help you memorize. And what else is here? Yeah, oblique fissure, horizontal fissure only found, sorry, oblique fissure, my bad, horizontal fissure is only found in the right lung, not in the left lung. Left and right oblique fissures are present. So right is found, right has oblique fissure and left has oblique fissure as well. Okay. All right. So these kind of questions are what is going to come in the exam. Why not A? Okay, let's go back to A. A, I said oblique fissure. So oblique fissure is found both in left and right. Okay. Where is the notch exactly? Okay, so let's show you guys notch first before we move on anywhere else. No, okay. Let me stop screen sharing and get you a picture of the left lung, the cardiac notch. Okay, so this is a very good picture. So let me screen share again here. Okay, so this right over here, this here is the cardiac notch. All right, this thing that the notch, it's basically the notch, it's kind of like something poking out. So this thing here, it's the notch, it's the part of the lung coming out. Right here is where the heart is sitting. So this is the place of the heart, the cardiac notch. This is where the aorta goes. Can you see this? This is the arch of aorta over here, and this is the descending aorta. Similarly, this area, this is the cardiac impression. That's where like the heart goes. The notch is the part of the lung that like comes out because of the heart being there. And then we have the aorta right here, and this is like a groove for the aorta. All right. Is it clear now? Okay, clear. All right. Okay, so let's go back to this part. All right. So the lungs have 3 surfaces. Okay. Why are there 2 impressions on the left lung, cardiac and aortic? Okay, yeah. So the cardiac impression, it's because of the heart being there. As soon as the aorta leaves the heart, it forms a groove. It runs on the left side of the lung it's more towards the left side, not the right side. All right. Remember that the heart pumps the blood through the left side, and the veins return, the inferior and the superior vena cava comes from the right side, right? So that's why it's towards the left a little, and that's why you can see the aortic groove on the left side. Can you tell which vein passes through the grooves of the right lung? Yeah, we'll go into it. I'll tell you at the end, okay? All right, so we have 3 surfaces of the lungs. We have costal, mediastinal, and diaphragmatic. All right. The mediastinal surface is the surface which is towards the heart. It's the middle surface, the surfaces of the lungs that face the heart, okay? This surface has the hilum, all right? The hilum, I'll show you what a hilum exactly is, but the hilum is the portion of the lung that contains the bronchi, the blood vessels, and the veins. The left lung has a continuous arch of aorta and descending aorta. I just showed you that in the picture, right? You saw like a groove, an area, an impression for the aorta to go, right? It was against the left lung. That's the impression of the aorta. The diaphragmatic surface forms the base of the lung, and it has sharp borders that dip into the costodiaphragmatic recess. So the lung, it goes down like this. When it goes down like this, it forms a pocket. This pocket is called the costodiaphragmatic recess. So if you see over here, this here is the costodiaphragmatic recess. The lungs, they dip down like this against the mediastinum and against the pleura. This is a very important landmark when identifying any pathologies wrong with the lungs. Every time you get an x-ray of the lung or of the chest, the first thing that you should look at, whether it's an OSCE or an MCQ, one of the very first things that you should look at is this angle, this small teeny tiny triangle. See if it's empty or if it's full. I'll show you what it looks like when it's full, but when it's empty, this is what it looks like. It's black, it's completely black. Okay, so this is a healthy lung. This is one of the indicators that everything may be right, not always, but may be right in the lungs. All right. All right, and so a question might come that which surface of the lung forms the costodiaphragmatic recess? So what are you going to say? The diaphragmatic surface. All right, now someone asked me what the hilum is. So here's what the hilum is. The hilum is the entry point for things like bronchi, pulmonary artery, pulmonary vein to enter into the lungs. All right. So that area is called the hilum, and plural is hyli. So lungs are attached to the mediastinum through the roots. So the root is basically, the root contains everything that the hilum contains. What does the hilum contain? You have, or let's go backwards. What does the root contain? I'll show you what the root of the lungs look like. But what does the root of the lung contain? It contains the bronchi, so with their vessels, the tracheal tree, the airways with the blood vessels. Over here, you can see it right here. Where's here? You can see these like small arteries around the bronchi. That is the bronchial vessels. The pulmonary arteries, these big ones, the ones that come from the heart, and the superior and inferior pulmonary veins. You have the pulmonary plexus as well. There's just like a group of nerves, and you have the lymphatics. So all of these form the root of the lung, which contains the contents of the hilum. This entire thing is the hilum that you're seeing. All right. So hilum of the lung is a wedge-shaped area on the mediastinal surface of each lung. It's present on both, but the contents sometimes, like the orientation differs. As you can see here, the bronchi, the artery, the vein are next to each other. Over here, they're on one top of the other. This may come as an OSCE question, by the way, but since it's not the focus of your anatomy lecture, I'm not going to go into it. But an exam tip would be to know the differences in the hilum, okay, and the differences in the impression of both the lungs. What does the right lung have the impression of? What veins and arteries the left lung has an impression of? Where the esophagus might be, where the esophagus might have its impression. It's not part of the anatomy lecture. I didn't see it in Dr. Atha's presentation, so I won't discuss it, but an OSCE tip would be to know those very, very, very well. All right. Okay. All right. So I want someone, these were mentioned in the lab. Yeah, exactly. They were mentioned in the lab. I don't think that they were mentioned in the lecture. I didn't see it in the lecture. So yeah. All right. So I want someone, now we're going to be talking about the bronchi and the branches of the bronchi and the trachea and all of that. Is it wrong to say that lingula is part of the cardiac notch? No, it's not wrong to say that, but you can say that lingula forms because of the cardiac notch. Clear? So you can say that. All right, so who can help me identify these labels? So someone unmute and help me identify the label. Okay. I will get to your questions in a little bit. Let's finish the slide. We reach checkpoint and I'll answer the rest of the questions, okay? Someone unmute, come on. Before I pick, don't make me do that. Can someone volunteer?
Yes, I'm here.
Yeah, go ahead.
Okay, so the first one is larynx, the one at the top.
Very good.
Then we have the trachea.
Okay, excellent. So now
Then we have
identify this one and this one.
right. This one is Karina.
This point, yes, excellent. This point is carina, but the carina is the angle. This is pointing at something else. What is this pointing at? Okay, so I'll help you. It's basically the bifurcation. So you're correct. The carina is basically the angle that you see at the bottom. It's the angle. But this point here is where the bifurcation happens. So this is the bifurcation of the trachea. Very good. And that's the angle called the carina. What is this? What are these two?
The main bronchus.
Okay. Yes, right and left main bronchus. Very good. So this is the left side. This is the right side. Now try identifying this label, this right here, and try identifying this label. It's the same thing, but on right and left. These two.
Is it the primary bronchus?
Okay, let's see. No,
Oh,
it's secondary bronchus. Primary bronchus is another name for left main bronchus. Clear? Secondary bronchi is a different thing. Okay, so the primary bronchus is this one. The left main bronchus is also called primary bronchus. Secondary bronchi come from the primary bronchi or the main bronchus. Clear? Try identifying these over here. So there's primary, then there's secondary. So what would this be?
tertiary or the segmental bronchus?
Excellent. Tertiary or the segmental. So another name for tertiary bronchi is segmental bronchi. Clear? Another name for primary bronchi is main bronchus. Clear? And what about the last one?
The terminal, the
Excellent.
bronchial.
The bronchioles or the terminal ones. Very good. So everyone who answered correctly in the chat, great, good job. Again, something that you need to know. I thought that instead of like putting it as text, we should make it interactive. So good job for everyone who got it correct. All right, so we're almost towards the end. We just have a few more things left. Now let's talk about the vasculature of the lungs. Okay, so first we're going to talk about the arteries, and then we're going to talk about the veins. About the arteries, like I mentioned, that arteries, they branch. They go from big to small, then teeny, then tiny, and all of that, right? The veins, they're the opposite. They are tributaries. They go from small and then they form big veins. So how does it start? The blood supply of the lungs. We talked about the thorax. We said it was the intercostal arteries. We're now at the lungs. Don't confuse those, okay? The lungs are supplied by the pulmonary trunk. The pulmonary trunk begin at the sternal angle or the angle of Louis, right over here. The pulmonary trunk divides into right and left pulmonary artery. Okay, so right and left pulmonary artery, those then split into lobar arteries. Lobar arteries supply the lobes of the lungs. The different lobes of the lungs are supplied by lobar arteries. Then lobar arteries further split into segmental arteries. Now, remember how I said everywhere in the body, wherever veins go, wherever veins go, arteries follow, right? But in the lungs, interestingly, wherever bronchioles go, arteries follow. So if we go back to the previous picture, let's go back here. Notice that the arteries are going to be literally named the same way: segmental artery, lobar artery, terminal arteries. Similarly, over here, we have the right and left pulmonary artery, just like the right and left main bronchus. Then we have the lobar arteries, which supply the individual lobes of the lungs. Then we have the segmental arteries that supply the segmental bronchioles or the bronchioles itself, right? The tertiary, not the tertiary, the very, very, very tiny ones that later form into alveoli. And it's these segmental arteries that form the capillary network around the alveoli. Now for the vein, go opposite, entirely the other way around. But for the veins of the lungs, it's actually very easy. We have the middle pulmonary vein, which then forms the superior and inferior pulmonary vein. That's all that you need to know. That's all that I think is important. like for the exam, but for details, definitely go back to Dr. Atif's lecture. But this is like the main important chunk of that lecture, okay? All right, so a 70-year-old male with pneumonia complains of difficulty in breathing. Physical examination indicates decreased lung expansion and breath sounds over the right side of the chest. The physician suspects the presence of pleural effusion. Which one of the following locations is the initial site for pleural effusion? Now, for those who don't know, pleural effusion is basically like it's basically when okay, so who can explain what pleural effusion is? Let me, instead of me explaining, someone explain what pleural effusion is. I want to hear it from you guys. What do you think it is?
When the fluid leaks out of the...
Excellent, exactly. That's exactly what it is. So when the fluid from the pleural space goes out from the pleural space and it goes out in the lungs. Now, remember I said that there is a space that forms, right? This is where the pleural fluid will go. So where do you think, what area of the lung would have the pleural effusion? Okay, excellent, very good. So the answer is costodiaphragmatic recess. And what it looks like, I'll show you towards the end of the presentation. So stay with me, I'll show you what it looks like. It actually, like you can actually see fluid there, okay? So the costodiaphragmatic recess, that's why I told you it's so important for you guys to first look at the costodiaphragmatic recess, because this is like a pocket, an empty pocket, kind of like a space where the fluid can collect. Not just fluid, by the way, blood, what else, mainly blood and fluid, yeah. So this is like an area, like a pocket, okay? What is a costomediastinal recess? Not important to me. Like for me right now, I want you to focus on costodiaphragmatic recess. That's not the focus of the question, okay? All right, now let's talk about the diaphragm. So the diaphragm is basically, we said that it's used for breathing. We all know this. It is made above the right dome and the left dome, okay? So there's like a right muscle that comes here and the left muscle. The right muscle is kind of higher than the left one. And why is that? I mentioned at the very beginning, it's because the liver is present on the right side. So the liver kind of pushes the right side of the diaphragm a little up. And the diaphragm is made up of the muscular part and the fibrous part. So the muscular part, it's towards the end, the peripheries. The fibrous part is towards the middle. The fibers of the diaphragm, they come together and they form a tendon. This tendon is called central tendon. The reason why the center of the diaphragm does not have muscles is because if it will contract, the important structures that pass through the middle will be damaged, and we don't want that to happen, right? So that's the reason why in the middle we have the fibers, and in the peripheries we have the muscles. So the crura of the diaphragms, they are musculotendin bands. So the crura are basically like leaves of the diaphragm. They come from the anterior surface of L1 to L3 vertebra, okay? And the right crust is larger than the left one. All right, now I'm going into a very important part of the lecture I'm going into a very important part of the lecture. I saw your question. I'll answer it in a little bit, okay? That you must know and focus on. So the importance of the openings in diaphragms, what they are, what level they're present in is extremely important. So if I remember when I said that the muscles of the diaphragm are towards the edges here, okay? And in the center, you have the tendons. These tendons, they merge to form the central tendons. The fibers, this is the white thing is the fiber. They merge to form the central tendon. Through the central tendon, you have three very important structure passing. You have, in the central tendon, you have inferior vena cava. Then you have the esophagus and aorta. Now, why are the esophagus and the aorta passing through the muscles? It's because they are themselves muscles. The esophagus itself is a muscle. if it goes around the muscular part of the diaphragm, nothing will happen to it because it's very thick, it's very stiff muscle. Same goes with arteries. They're very thick and strong muscular wall, especially the aorta. Nothing will happen to it. But with the tendon, with the vein, with the inferior vena cava, if it is surrounded by muscles, when the muscles contract, the inferior vena cava will literally like collapse. We don't want that to happen. So that's the reason why it's surrounded by the central tendon. Now let's talk first about the caval opening. So the caval opening, very important for the OSCE, very important for the MCQs as well as the SAQ, is one of the openings from the 3 openings that we have is the caval opening. That's the first opening of the diaphragm. It's at the very top, and it's at the T8 to T10 vertebra, T8 to T9 vertebra, okay? And this opening allows for the inferior vena cava to pass through. Along with the inferior vena cava, you have the terminal branches of the right phrenic nerve. The phrenic nerve, right phrenic nerve, supplies the right leaflet of the diaphragm, so right segment of the diaphragm, along with some lymphatic vessels, okay? So inferior vena cava, right phrenic nerve, lymphatic vessels pass through the caval opening. And it's located in the central in the central tendon, in the junction between the right and middle leaf of the central tendon. And what location is it at? T8 to T9. Very, very, very important, okay? Where is the location? Like, where is the opening present? What are the contents? And that's it. Like, where is it present and what are the contents? Very important for you guys to know, okay? Next, we have the esophageal hiatus. So esophageal hiatus is basically, it's an oval opening for the esophagus in the right crust of the diaphragm. So this is present on the right side. It's present at the level of T10, as you can see here. And along with this, 2 very, 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 very important nerves run through the anterior and the posterior vagal trunks, okay? The vagus nerves runs through the hiatal opening with the esophagus, and they form this muscular part of the diaphragm forms the internal sphincter. Do you guys remember from GI? You guys must have taken the internal sphincter and how when it relaxes it causes GERD. So this is exactly that thing from your GI. The muscular part of the diaphragm, the way it is, it kind of causes the esophagus to kind of like narrow this way. When it narrows, it causes a natural sphincter to form, and that is the reason why it prevents the reflux of stomach contents into the esophagus. Okay, so again, T10, what are the contents? The anterior, posterior vagal trunk with the esophagus. Very important. All right, the aortic hiatus. The aortic hiatus is the one that contains the aorta, okay? So this does not pierce the diaphragm. There's literally an opening. A hiatus is an opening. Remember, I said the caval opening? The caval opening meant that the vena cava, inferior vena cava, was literally piercing. During the embryology, I don't know if Dr. Paul taught you this. I'm pretty sure he did. The inferior vena cava literally pierces, goes right through the middle. But aortic hiatus doesn't do that. The aorta doesn't do that. There is a big hole in the middle for the aorta to pass through, okay? And the reason why it's this way is so that the diaphragm, the contraction of the diaphragm does not affect the blood flow, although it's thick, but we don't want the diaphragm to affect the blood flow at all, okay? Because there's high pressure blood in this. And the aorta, the aortic hiatus, the place that the aorta leaves the thorax and enters into the abdomen is the T12 vertebra. So before the aortic hiatus, the aorta was called the thoracic aorta. But now it's no longer called the thoracic aorta. Once it leaves the aortic hiatus, now it's called the abdominal aorta, okay? And it ends at T12. T12 is where the thorax ends, and this is when the abdomen begins. And so along with the aorta, you have the thoracic duct, in which all the lymphatics of the body drain in, and we have the azygous and hemiazygous veins. All right. Now, this is a very important table. So instead of like going into the details of the nerve supply and the arterial supply and the lymphatic drainage of the diaphragm, I got this table from Moores. It's not my table. I got it from Moores. So it basically summarizes everything that's in your lecture. I thought it would be easier for you guys to study from a table. Important things that you need to know: phrenic nerves. Okay. If you guys like, when you guys get this presentation, you can like write it down, and I think I have this in the notes section as well. Phrenic nerve, very important. Where it comes from, very, very, very important. C3 to C5. What is its sensory supply? And then what else is important here? Venous drainage is also important, and obviously arterial drainage, arterial supply. What part of the diaphragm is supplied by what? And yeah. Okay, so now we're going to go to questions. Before we get to my questions, let me see if you guys have any questions, because now we're done with the lecture. Oh yeah, there was one more thing from Dr. Akif's PDF, the inspiration and expiration. Do you guys want me to go over that? I thought that it was pretty simple, but if you guys have problems, I can open the PDF and go over it with you guys. Do you guys want me to do that? We still have 20 minutes. Write it in the chat box. Okay, I go over it. I want more people to reply. So like, if we have a significant number of people, I'll go over it. You want me to go over the questions? Okay. Okay, so majority want me to go over it. So also the questions. Okay, so what we'll do the questions, then we still have time. So for those who don't want to listen to that part, they can leave. For those who want to stay, you can stay. So I know the questions are the most important part. We'll do those, and then those who want to stay can stay, and I'll definitely go over that. I don't mind at all. I just didn't include it because I thought that was like the simpler nerve supply and arterial supply. Okay. All right, so let's start. There's a 32-year-old man who's admitted to the hospital, and he has difficulty in breathing after an accident. So during the physical examination, he has no signs of any external injury and everything looks normal. But when you see the patient, you notice that there's dyspnea. Dyspnea means shortness in breathing. Okay, that's what dyspnea means. And it is becoming worse. So what do you think is the diagnosis of the patient? So first, I want someone to look at this picture and tell me what they think is going on.
Something is wrong with the left costodiaphragmatic recess.
Okay, something is wrong with the left side. Okay, good observation. What do you see on this side? What do you see on this side? Do you guys see a difference? Okay, I'm getting some correct answers in the chat. Okay, anyone else? All right, okay, so I'll explain. Oops. Okay, so those who said that this is a pneumothorax, they're absolutely correct. This here is the collapsed lung that you see. Now you were correct to identify the something wrong with this costophrenic angle, and you're correct. There is something wrong with this, and there's something wrong here as well. So you guys see this outline right here? This is the lung. So what happened was that the cavity, the pleura, was pierced, and the lung was deflated, and all the air from the lung went out. So the lung literally shrunk and collapsed. This black thing that you see, whenever you see this in the x-ray, in the exam, you might get this x-ray, because I saw it in Dr. Atta's presentation. Whenever you see something like this, no, this dark thing that you see here is it's pneumothorax. That means that there's air here. Air always appears black on an x-ray. All right, so here there is something missing, and this is the lung. You're going to see the lung outline. Another way to identify that this is pneumothorax is on this side, you see vascular markings. So you guys can see the blood vessels, right? All over here. But can you spot them on this side? No, they're very faint. They're not present all over, as opposed to here. They're more visible on this side. So because of the lung shrinking, it's caused oppression. And those who said that this is cardiomegaly, you weren't wrong. You were almost correct. Because if you can see, the heart is pushed on this side. Look here, like this heart is pushed there. So you were correct in identifying that there's definitely something wrong with the heart. But it's not the heart that there's something wrong with. It's just that because of the collapsed lung, because of the pressure, it's pushed the heart on the other side. And that's the reason why the costophrenic angle is obstructed. All right. Now let's go on to the next thing. Oh, I had something in the chat. Makes more sense. Yeah. Okay, so if there is fluid, it appears whitish on the x-ray. Yes, if there is fluid, it appears whitish on the x-ray, and I'll show you what it looks like. I didn't include a picture. I forgot. I will show you from Google in just a minute. Okay. So this is a 37-year-old man who's brought to the emergency department and is complaining of severe chest pain. His angiogram reveals thrombosis of both brachiocephalic veins. This condition would most likely cause a dilation of which one of the following veins? Go ahead. Oops. Okay, my bad. Okay, yes. So left superior intercostal vein is the answer. Why? It's because the left one drains into the brachiocephalic vein. All right. And yeah, I'm sorry. I showed you guys the answer. I will share this presentation with you. Now, for those of you who were at, okay, is everything clear before I go on to the questions? Oh yeah, before you guys leave, let me show you what pneumothorax looks like. Hold on. Okay, so let's actually go back to your presentation that Dr. Atif shared, and I'll show you what pneumothorax looks here, just so you guys are familiar with it. Okay, so in this slide, you can see that here, right over here, this was the pneumothorax on the side, and you can see that there is air. Pneumo means air, all right? Effusion means effusion means when the fluid leaves through the pleural space. Hemo means blood. So when there is air in the pleural space, like you saw in the picture that I showed you, it's dark, it looked black. That means that there is air in the costodiaphragmatic recess. This is a sign of pneumothorax, which looks like a collapsed lung. This is a collapsed lung here. The heart is pushed onto the side. That's why it looks bigger. And there's air in the costodiaphragmatic recess. Here, blood always appears white, okay? Blood appears white. Remember, I said fluid and blood, so water and blood appears white. Air appears black on an x-ray. When you see this, your brain should be like, either it's blood or it's water, pleural effusion. So because it's so massive and it's covering almost like, look, it looks so opaque. It's all over the place. It's diffuse. That's why this is hemothorax. This is blood in the pleural cavity. And there is no costodiaphragmatic recess visible here. As for a pleural effusion, just a second. Okay, so over here, let me share my screen with you. Here, as you guys can see in this picture, see how you can't see this patient's costodiaphragmatic recess. It's not visible. The reason why it's not blood, it's because if you see the blood one, if you see hemothorax, it's literally spread all over. Like this can be hemothorax. Why? Because you see it's spread all over. It's blood. It clearly looks like it's bleeding because it's all over the place. Where it looks like layers of the lungs were pierced and blood went from one side to the other. This possibly cannot be pleural effusion. Like it's very hard for it to be pleural effusion. And to be honest, at your level in year one, you would by the question, you would be able to tell if this is hemothorax or if it's pneumothorax. Okay, hemothorax, the patient would be covered in blood or something, and when they will say something in the auscultation, this and that, and you can clearly tell that yes, this is blood. For pneumothorax, it won't be that way. It may be like, okay, the patient was stabbed or something that would indicate, there would definitely be a clue that this is pneumo, not hemo. Again, here it's only on one side. This is pneumothorax. It can, honestly, it's a very bad x-ray, so it can be both. I really can't tell. I'm not an expert, to be honest, but yeah, I hope that's clear. All right, so let me go and explain the inhalation and the exhalation process. Okay, so very quickly, we'll go over it. For those who want to leave, you can leave. Thank you for coming. And if you have any questions, please email me. I will email or I will tell Idris about the questions that you guys asked that I wasn't able to answer. All right, so let's quickly discuss this. We have 10 minutes and inshallah, it's going to be easy. It's not that difficult. Okay, so the joints in the thorax, I hope that it's clear. It's simple. Every time a bone meets, it forms a joint, right? So we have the manubrosternal joint between the body of the sternum and the manubrium. This is the manubrosternum joint. Then we have the sternocostal joint, which is between these costal margins, so the cartilage of the ribs and the body of the sternum. And then we have costochondral. Chondral means cartilage. So anytime that, costo means cartilage, my bad. So anytime that a bone and a cartilage meet, they form costochondral joints, all right? Interchondral means, cartilage, right? So between the two cartilages, it's intercostal. Okay, now when we breathe, the rib cage expands in 3 directions, all right? It expands this way, it expands this way, and it also expands, the ribs are usually facing downwards a little, as you can see in this picture. So they also expand straight, they also go straight. So again, rib cage expands in 3 directions, like this, and the ribs go from this way, they go a little straight like that. All right, so now the ribs are divided into cervical ribs, upper ribs, lower ribs, floating ribs, right? Same terminologies that I used, almost the same. So we have the cervical ribs, which is the first rib, that's a single rib. Then we have the upper rib from 2 to 6. Then we have the lower rib from 7 to 10. And then the floating ribs are 11 and 12. Now, the way the rib cage moves is a little different. So when you inhale, when you take in a deep breath, the upper ribs, they move in the pump to handle movement. What does that mean? We'll see this in the picture here. So they're facing downwards. So they go from downwards to a little upwards. Whereas the lower ribs, these ribs, they're facing also downwards, but their angle is a little different. Because of the angle being a little different, this movement is called bucket handle movement. Same thing, literally the same thing. It's just that because of the different orientation of ribs, as you can see here, the ribs go down from the vertebra and they attach at an angle at the sternum. Why is it this way? It's because when we inhale, when we take a deep breath in and the lungs inflate, they have room to move. The rib cage has room to expand. Otherwise, the ribs would just break. So that's the reason why the upper ribs have a pump to handle movement, and they increase the anterior-posterior diameter, which means that this diameter is increased. Here, this diameter is increased. There was a really nice picture here. So this diameter from here to here is increased. The bottom ribs, they move in a bucket handle way. That means that the transverse diameter, they expand this way. They go this way. Why? Because of their orientation. Clear? So again, lower ribs increase the transverse diameter. They go this way because they need to expand. They make this inlet, the thoracic inlet, bigger. And the upper ribs, they increase the anterior-posterior diameter, and that is called the pump handle movement. Okay? Now, the last movement that you need to know is the vertical movement. So this one, the vertical movement is increased by the diaphragm. So three things happen. You have the rib cage that moves, you have the muscles that contract, and you have the diaphragm that moves. When the diaphragm moves, this increases the AP diameter. This increases the vertical diameter. So the chest literally becomes longer, and it gives more room for the lungs to come down and up. This is called the vertical diameter, which is caused by the diaphragm moving downwards. They pull the lungs down. And that's exactly what's explained here. They may ask you about this in the exam. I can't remember if this came in my exam, to be honest. But they asked us, this is very important. I know that Dr. Atif really emphasized on this. So again, the upper ribs, so 2 to 6, they increase the anterior posterior diameter through the pump handle movement. The 7 to 10 ribs, they increase the buckle handle, they increase the transverse diameter by the bucket handle movement, and the diaphragm increases the vertical diameter through the transverse movement, basically. And that's it. I hope you guys are done. We are done, alhamdulillah. Do you guys have any questions? Before you leave, Idris, do you mind stopping the audio so I can give them like a few? We're done basically, so you can stop.